Sure. Let me just start by saying really delighted and honored to be a part of this forum. My name is Dave Choksi. I'm a primary care doctor, and I lead population health efforts at the New York City Health and Hospitals, formerly known as Health and Hospitals Corporation. Just very briefly about our system, we take care of 1.2 million patients across the 5 boroughs of New York City. Functionally, it's the poor and the working class of New York City. About a third of our patients are uninsured. The vast majority of the rest are on Medicaid. And I thought I'd offer 3 takeaways from my perspective in terms of what health systems need to do to help move this field forward. First, I would echo the slide that Arnie Milstein put up with respect to Denver Health's approach to actually matching up whole population risk stratification with the care models that are actually being delivered at a specific system. I think that is a fundamentally different way of actually thinking about how to deliver care. And it organizes our efforts in a way that allows us to look at what the gaps are with respect to where we're not taking care of high-need patients as they need to be taken care of. It's something that sounds very simple and is easy to distill down into a slide. It's much harder to operationalize in a way that feels seamless on the ground. And I think that's the piece that health systems are really struggling with because there are multiple siloed programs that often touch patients in very different ways. So that would be the first piece. Second takeaway is just the way that I think about the concept is meeting patients where they are. So essentially ensuring that we're taking into account the high-need patients that we're thinking of, the most marginalized patients that our health systems touch, and often those patients who we touch only when they're in extremis, when they come into our emergency departments, into our hospitals, instead of having a more proactive approach to reach out to those patients before they become the highest need patients. This raises a lot of thorny questions about how do we do resource allocation so that we're actually matching up the most intensive care models to the highest risk patients, but also trying to prevent them from becoming those high risk patients in the first place. I think another way to think about this is essentially to reconcile with the myopia that many health systems have. And then the third takeaway, very briefly, is to endorse a just get started approach to dealing with social needs in particular. One thing that has struck me as I suppose the delivery system representative here is that there's this illusion of behavioral health and social needs that doesn't feel authentic to me, at least based on how our delivery system is organized. Behavioral health is something that is, part of our fundamental set of services, and social needs is a much different orbit that we're still trying to figure out how to engage with community partners in. And so, our sort of just get started approach to this revolves around 3 issues: housing for our patients, thinking about food security, particularly for pediatric patients and their families, and then building on some medical legal partnerships that we have at a handful of our facilities. And so we're just getting started and trying to figure out the broader strategic issues with engaging with the social determinants of health. Thanks.